Hello, my name is Nick Taylor. On behalf of my co-authors, Sirawi Chavalit and Karen Dodd, I'm pleased to talk to you about our study, which has recently been published in Developmental Medicine and Child Neurology. I'd like to talk to you about some of the ideas and thoughts we had in designing our study. The key thought was whether sit-to-standing training could improve self-care and mobility in young people with CP. On the one hand, perhaps sit-to-stand would only improve what was being trained, the ability to sit-to-stand with little carryover into function. On the other hand, if sit-to-stand training is an important precursor skill for activities requiring upright posture, if it became easier, then upright mobility and self-care tasks requiring upright mobility would also become easier. This was something we discussed a lot and was the central idea behind the study. The second thought was that sit-to-stand training would only make sense if someone already had difficulty doing the task. That is, there would be no point training a task that can already be achieved without difficulty. Therefore, we targeted our training to children with moderately severe mobility limitation, classified at GM-FCS levels 3 and 4. The third thought was that if we were going to train sit-to-stand according to task-specific training principles in young children aged from 4 to 12 years, there would need to be a lot of practice and a lot of supervision. We knew we'd have to involve caregivers in providing supervision at home. We couldn't just rely on physiotherapists. We were concerned that this might place too much strain or burden on them. With these thoughts in mind, we conducted a randomized controlled trial comparing the addition of sit-to-stand training to usual physiotherapy alone. The program was conducted consistent with the principles of task-specific training, 5 times a week for 6 weeks with a target of 75 repetitions of sit-to-stand in each session. 3 of the sessions supervised at home and 2 supervised at physiotherapy. In the first phase, in each session, seen in the left panel, the participant practices components of the task, in this case, forward weight shift. In the second phase, the participant completes the whole sit-to-stand activity. The third phase involves incorporating sit-to-stand into function, for example, by reaching for a toy after standing. So what were the results? Here are the results of independence in mobility. At baseline, you can see the experimental and control groups are very similar. After 6 weeks training, you can see on the right that the experimental group had increased independence in mobility while there was no change in the control group. There were similar results of between group differences favouring the experimental group for sit-to-stand, performance and self-care. Interestingly, we found not only that there was no increase in caregiver strain, in fact, there was a reduction in strain reported by caregivers of children in the training group. In conclusion, we found a sit-to-stand exercise program for children with CP classified at GM-FCS levels 3 and 4 improved sit-to-stand performance and resulted in small improvements in self-care and mobility while reducing caregiver strain, thereby providing support for the hypothesis that the ability to sit-to-stand independently is an important precursor skill for children with moderately severe mobility limitation. Thank you.